Well, good morning and welcome to day 4 of the PFF Summit. We're so glad that you're here again. I'm really happy that you were able to join us for this session today on supplemental oxygen. Supplemental oxygen is one of the issues that PF patients often struggle with the most, but is also so important to their care. So we're really glad to be able to offer this session today. We have a great lineup of speakers that are going to provide some insight into navigating supplemental oxygen. Our first speaker is Susan Jacobs. Susan is a research nurse manager in the Division of Pulmonary and Critical Care Medicine, as well as a nurse coordinator in the Interstitial Lung Disease Program at Stanford University Medical Center. Her background includes roles as a critical care nurse coordinator, NIH project director for a shortness of breath and exercise study, and pulmonary rehabilitation program coordinator. She works closely with us here at the Pulmonary Fibrosis Foundation as an ambassador on the medical advisory board and the board of directors. She coordinates the Stanford ILD support group and educational seminars for PF patients and families. Her clinical and research interest areas include improving quality of life issues related to oxygen, shortness of breath, and cough. She's the lead author on the results of the first national patient survey of almost 2,000 supplemental oxygen users in the US. Melissa King will be our next speaker. Having smashed the oft-quoted 2.5 to 5 year life expectancy stat, Melissa has been living with pulmonary fibrosis for over 7 years. She has been an ambassador with the foundation since 2018. And finally, we have Mike Sampella. Mike is the Regional Account Manager for Adapt Health in the state of Delaware. He has been with Adapt Health since 2012. Please enjoy our show.
I'm Susan Jacobs. I'm a research nurse manager at Stanford Pulmonary Medicine and also a nurse coordinator in the Interstitial Lung Disease Program at Stanford. And today we'll be discussing Supplemental Oxygen 101. No disclosures. And I want to start by saying, first of all, there's about 1.5 million people in the United States using supplemental oxygen at home. So this is a significant area for patient education. And this diagram you're looking at was a publication in our ATS workshop that identified how we would define optimal oxygen therapy. And you can see today we're going to talk about and focus on 3 of these areas: education, testing, and some of the equipment. So we'll cover the assessment for the need of oxygen. Then we will move on to navigating the oxygen prescription. And finally, we'll spend a bit of time on the recently released ATS, American Thoracic Society, Oxygen Clinical Practice Guidelines. So the first challenge is getting the oxygen into the blood. Patients that are prescribed oxygen have a problem getting the oxygen from the air sac across this alveolar capillary membrane, which is this wall right here. This is the air sac, this is the blood coming past it, and this is the alveolar capillary membrane, or also known as the interstitium, where oxygen passes through. So in patients that have interstitial lung problems, due to either inflammation or scarring, there's some type of injury to this wall and an abnormal wound healing process that really lays down scar tissue, inflammatory substances, and really then inhibits the crossing of oxygen into the blood. And you can see on CT scans, normally we don't have any of these thickened markings, but on a patient with pulmonary fibrosis, you can see these, what we call interstitial markings, really signify that there's a density now to the lung tissue, which represents that scarring. So how do we determine your oxygen level? We can, most commonly, we do it indirectly with a pulse oximeter. We can do it directly by taking an arterial blood sample, which we sometimes do in the hospital or during a complete pulmonary function test evaluation. Now, if we measure your blood and determine you need oxygen, many patients will report back to us that despite starting oxygen, they're short of breath. And even patients who haven't been tested for their need for oxygen may tell us they're very short of breath and therefore they feel that they need oxygen. So if you're breathless, it doesn't necessarily mean that you need oxygen. The cause of breathlessness in patients with pulmonary fibrosis can vary, but some causes can be that you have a greater effort and work to breathe because your lungs are a bit stiffer. You can also experience breathlessness because of muscle deconditioning, carrying extra body weight, and having some anxiety and panic. So how to determine if you need oxygen? You may, if your oxygen pulse oximetry, that's on the finger, is less than 88%, or actually equaling 88%, would qualify you under Medicare guidelines. So we would measure your resting oxygen, your oxygen levels with activity, such as a 6-minute walk. We might take you upstairs. During sleep, you can be provided with a special oximeter to have overnight testing, and we can download that data into a computer and determine what happened during the night while you were sleeping. And also we can measure oxygen at altitude, either when you're at altitude, or we can simulate altitude in our lab by having you inhale and breathe a concentration of oxygen that's lower than what we would have at sea level. So it simulates altitude. And that's important if you're going to travel, which you'll hear more about in another presentation. So the prescription of oxygen is based on the testing results. And for example, this is a patient in our hallway at Stanford undergoing the 6-minute walk. So at rest, this patient had a saturation of 95%. When he started walking, he dropped to 86%. So oxygen was added at 2 liters a minute. And he still, with walking on 2 liters, was down to 87. So it was increased to 4 liters per minute. And then he was able to keep a saturation above 90%. So therefore, for this particular patient, he had a prescription of no oxygen at rest, 4 liters with exertion, and probably would have some testing to determine if he needed to use oxygen during sleep. And the last point, number 5, is important. It's important to get follow-up over time if your oxygen needs changed, because you would have to be retested and get that information to your supplier to perhaps get more tanks per week or a different type of oxygen system. The next section we'll discuss is navigating that oxygen prescription once you've been provided with the orders and the testing that you do need to use supplemental oxygen at home. So the process through the Durable Medical Equipment Company, which we call DME, is that your physician will send results of that testing with some documentation to a durable medical equipment company, and your provider can let you know what companies they are. Most of us have companies in our area that we work with. Some are national, some are local. Those orders will document exactly what you need in terms of flow rates or settings, and we really want you to let us know if you have, for example, many stairs to get up to where you live, or if you use a walker, for example, or if you're out of the house many hours per week, you're working or going to school or caring for grandchildren, going to pulmonary rehab, because that'll help determine how much of a portable supply you would need. And then a stationary, meaning one that stays in your home, and a portable device, one that goes out with you, will be delivered. Unfortunately, right now we're seeing fairly limited options. Most companies might, for example, only carry one type of portable oxygen concentrator. So you can check around with companies if you, for example, know that you need a lightweight system or that you need lots of small tanks, and see in your area which companies offer which types of equipment, and work with the staff at your physician office, or even the DME. You can discuss these with them as well. It's important to know that we have to have that testing done within a month of you getting the equipment. So if you get tested in the office and a month passes and then you go to a company and we send those orders, they'll want you to come back and be retested. So it is important to keep that process going quickly once we've tested you and sent in that information. And then, as I mentioned before, it's important to get retested either at your visits. Some of you might be tested as often as every 3 months, some every 6, some annually. You're all very different in how your lung problems progress or don't progress. But if you did need more oxygen, we would need to send in a new order so that company could provide you more equipment and more tanks per week, or a different system that went up to, for example, 6 liters per minute. So what kind of equipment is prescribed? In terms of oxygen systems, you can have compressed gas, the ones that you see most often in those green hard tanks, the cylinders, concentrators that use a battery or electricity, or liquid. And as I mentioned, not all companies offer the same equipment, and you do start with a 5-year contract. So it's important to start off with the equipment that meets your needs, because it's very difficult to change companies if you made that decision. So the different types of flow, this is important. Continuous flow goes throughout the breathing cycle. It's flowing through that cannula continuously. Pulse or demand flow only flows into your nose when you take a breath in, and it triggers a mechanism in the system to pulse and send a bolus of oxygen into your nose. There's 2 different types. This is getting into a bit more technical. Minute delivery means that no matter how fast you breathe, you'll get the same amount of volume in that minute. But most commonly it's a fixed pulse. I'm sorry, the other system is fixed pulse, which means no matter how fast you breathe, you'll get the same amount each breath. So in the minute volume, for example, if you breathe more rapidly, the volume in each pulse goes down, because you're always getting the same amount in a minute. If you breathe more slowly, the pulse amount goes up. This really only is reflected in if you're exercising. We want to make sure that that equipment triggers adequately. And the bottom line is, what does your pulse oximeter tell you when you're using that system on pulse and you're doing activity? So that's what we really want you to check. Some POCs are now being marketed during sleep. This is fairly recent. So you do want to check with your physician and maybe even have overnight oximetry on that particular system. And I want you to remember, for all of you, that 4 liters on a continuous flow may not give you the same oxygen saturation as a POC that's on this pulse dose setting of 4. So 4 on a POC may not equal 4 liters per minute on those green tanks. And the only way to really know, again, is checking your pulse oximetry. And even to complicate things further, we know that among the different POCs, even a setting of 2 on one might give you a slightly different amount of oxygen than a setting of 2 on another. So again, the bottom line is really knowing what your pulse oximetry is when you're moving about using your own system. And we want you to tell us how it's doing. So compressed gas, you can see there's a variety of sizes, tanks, and there's one system we call a home fill. You can actually fill your tanks overnight and have them, you have 2 or 3 tanks to fill. They come in many sizes. You can use these with a regulator on them, like you see here. So some can be on continuous flow, and you can switch it to pulse flow, which does help conserve the amount of oxygen and how long that tank lasts. Compressed tanks, you can see these are our patients in a variety of settings. This is somebody who's really has to take with her. She's on very high flow, 6, 8, 10 liters. So this is what we need technology right now to get us a better system. He's been very innovative to keep exercising. This is 2 e-tanks, a patient with a walker who had a friend of his rig it so he could use his walker and have 2 e-tanks. And then this is a patient with a more rare lung disease, but she has high flow oxygen and she plays tennis. So this allows her to maintain her active and mobile lifestyle, which is what we want. So concentrators are a different type. They take the room air around you and bring it through these sieves, or kind of a filter, to remove the nitrogen. You can see they come in all shapes and sizes. These are portable ones. This is the one that might be at home. The way it works is it draws the air from the outside in through these we call sieve beds, like here. It pulls the nitrogen out and then delivers the oxygen more purified, about 95 to 98% to you. So the benefit is these can run off DC power, can run on your car. They're FAA approved. This is the only type of oxygen that can be used for travel. The battery for travel, and you'll hear more about travel issues, but the battery will last a shorter amount of time with the higher flow rates and a higher respiratory rate. It's very important that you get tested on these systems before you order them. Some patients pay for these out of pocket. These are $2,000 to $4,000. It is very important to make sure they're adequate for you. And what I want to emphasize is this bottom point. There's no POC that runs continuous flow greater than 3 liters per minute. And the ones that are 3 are these big ones that are about 20 pounds and not very portable. And the pulse settings only go up to about 6, more commonly 4 or 5. So again, it's just important before you purchase or start with one of a POC that you make sure it delivers enough oxygen to keep your saturations above 90% when you're exerting yourself. Liquid oxygen is another form of oxygen. It's very rare now to be available primarily because of its cost. This is oxygen that's been cooled down. It's very convenient for mobile patients because you can fill your own tank. These are tanks that will hold a far more, that hold a greater quantity of oxygen in a smaller space, and they go high flow. So this is the big advantage of liquid. You can take a canister and be 6 liters and be out for a couple of hours or longer. The problem is that it's a very costly form of oxygen. The drivers have to deliver this every week to refill this tank. Takes longer times to service, and the companies need to have very specialized equipment that's expensive to purchase. And because of the reimbursement system, we've seen liquid oxygen virtually almost disappear. Which is something that advocacy groups are working on, particularly focus on those patients that are out of the house and need high flow, 4 liters per minute continuous and higher. There's some cannulas that will help conserve your oxygen. You can see them here. The one's a mustache, not very aesthetic, but this is a pendant. They actually act as a bit of a reservoir and increase the concentration of the oxygen flowing in, and could allow you to let your canisters, this is for, can't use them with POCs, and they can't be used with pulse, but your E-tanks or your tanks might last longer, or you might be able to use a setting of 4 instead of 6. We'd also encourage you to conserve your oxygen if you can turn it down when you're resting, and you don't need to keep your saturations very high. As long as you're above the 92 range or whatever your physician tells you, that's fine. It'll also help preserve your nose and decrease problems. The last section I'd like to cover is just to highlight the recent American Thoracic Society Oxygen Clinical Practice Guidelines. These were recently published and represent an expert panel reviewing the key studies and data that are available that provide kind of the underpinning of why we prescribe oxygen. And this was a gap determined in our workshop. So it's a multidisciplinary panel with a very rigorous and systematic approach. I know you can't read the fine print, but I just want to give you the overall view that we asked 6 questions. There was a methodologist that then went to the literature and reviewed every possible study. We looked at COPD patients and asked also about ILD patients, similar questions for both. What was the evidence to prescribe oxygen for those who have low oxygen levels at rest? We call that resting hypoxemia. And then focus also on patients who are okay at rest, but they desaturate when they exert themselves. So for the interstitial lung disease patients, those were the 2 questions we focused on. Should we prescribe oxygen for patients who have low levels at rest? And should we prescribe oxygen for patients who have low oxygen only when they exert themselves? So there were no studies done on ILD patients with resting hypoxemia. So we used the results of these key studies that were done. This was one in the 80s. There was another one with similar results. And you can see for the patients who had resting hypoxemia, in other words, they're sitting quietly and they have low oxygen, Their survival was improved over years when they used oxygen at least 15 hours a day continuously, compared to those patients who were randomized to the group who used either no oxygen or only with sleep. So this is a statistically significant improvement. So that's why we base our recommendation for patients with ILD who have resting hypoxemia to use oxygen, although it was based on very low quality evidence. The next question was, do you need to use oxygen with exertion? These are patients like many of you who only desaturate with exertion. So again, we looked at as many studies that were available as possible. There weren't a lot. Some only looked at 6-minute walk before and after, not like at home. One blinded study did find a benefit in quality of life. And some others, when we grouped them together, found benefits with exercise, but not a difference in breathlessness. So the summary finding is really a recommendation for patients and caregivers who are using ambulatory oxygen. It is burdensome to have this discussion with your physicians and caregiver providers to see if the benefit for you of improving your breathlessness and activity level is applicable. Some patients don't find that helps them. Perhaps those that just have a little bit of hypoxemia, maybe in the high 80s, but others who desaturate profoundly clearly tell us there's a benefit. So it's a very individualized decision. It's different than if you have it with rest. If you're low oxygen at rest, the evidence is clear that it will help survival. Just with exertion, the evidence is not as clear. So this is just, again, what I just said. If you're at rest and you have a low level, that your survival can be improved. And we look at all these characteristics of the trial to make sure that that trial was done well. And again, if it's just with activity, our guidelines suggest that you use it based on low quality evidence. The good news is we are now doing studies to try and fill this gap in research. Lastly, there were 2 areas. We do recommend liquid oxygen for patients who have high flow needs and are mobile. And we also recommend a standard of education for everybody. And there's many resources available to all of you. So we'd recommend that you really take advantage of these. Thank you very much.
Hi, I'm Melissa King, and this is Traveling with Oxygen. I am a Pulmonary Fibrosis Foundation ambassador from the Buffalo and Niagara region of Western New York. Buffalo used to be not so great, and every year it's getting better and better. So this is a lovely picture of Buffalo and also Niagara Falls when it was turned blue for the Pulmonary Fibrosis Foundation. And there's a little icon of me rooting on the Bills, which is much easier this year than it has been in other years. I am married to a wonderful man named Richard, and I have 2 beautiful children. My daughter Adriana is in the middle there, and my son Zach on the end. We own a small candy and ice cream shop, and this is the 4 of us all there when we were sort of quasi working. So you can see I have my oxygen on there, and as a patient, I have a little different perspective than what Susan can give you. I don't maybe have the schooling that she does, obviously, but I have used the oxygen every day for 7 years. So I can give you somewhat of that patient perspective. And especially if you're new to the oxygen, hopefully I can share some things with you. The biggest thing is not to let oxygen stop you doing anything. That's what I've always tried. So you can see in these slides here, there's just a few here of me swimming, going on a boat, there's a picnic. I do Halloween every year to pass out candy. Well, I didn't last year because of COVID, but usually I made my shirt beating pulmonary fibrosis when pigs fly, and I had my flying pig hat. So always trying to do something. My family went down to Shays, downtown Buffalo here, and saw Hamilton. My son was in a play, and you can see that took quite a bit of oxygen to get through. And my husband and I went to a Sabres game, which that takes a lot of oxygen even for a regular person. Now, if you follow hockey, you know what I'm saying. My first road trip was back in 2015. My sister and I drove down to Washington, D.C. to the Pulmonary Fibrosis Summit. And we had one afternoon off, and you can see we did all the touristy things that one does in Washington. We ran, well, we didn't run. We walked down and walked from place to place. And so for me, I love my oxygen because it enabled me to do these things. Without oxygen, I would have never been able to do that walk. And it was amazing. I had never been to Washington, D.C., so I was really excited to be there. And you can kind of see on my face, it was just exciting for me. Since then, we've done a few things. One of the things we tried to do as a family, we wanted to go to the Caribbean to kind of do this like bucket list trip. And my oxygen company, I will talk about this in just a few minutes. My oxygen company said they didn't service there. We'd have to stay in the 48 states. So we decided to go as far south as we could, and we picked the Florida Keys and got that all set up. And about 3 weeks before we were to leave, they called and said, oh yeah, they don't service the Florida Keys either. But everything was set at that point. So what we did is we flew into Fort Lauderdale, or Miami, Fort Lauderdale, I believe. I secured a motel room for one night and had the oxygen delivered there. We did not stay in that motel room. We stopped there, picked up the oxygen, and then drove to the Keys. And then when we were done, we drove back and flew out of there. We dropped off the oxygen, and that worked out for us. So as I said, I'll be talking about that in a little bit, but you can see we were in Florida. Again, trying not to let being on oxygen stop me from doing anything. Flying, it used to be weird to wear a mask, and nowadays it's not weird. I've flown to Chicago. My daughter and I went to the PFF walk in Chicago there. So I wanted to swim with the dolphins. They wouldn't let me swim, but I kind of like waded with the dolphins. And if you look close on this slide, you can see my little tube there. My husband, this is my husband's foot. He stood on the side and kind of wheeled in the oxygen. And they told us as long as we kept it taut and it wouldn't get caught on the dolphins, it would be okay. So that was a really amazing trip that I highly recommend to anybody. Again, we've been back to Chicago. We went out to California, all things that I couldn't do without my oxygen. So you can see the one constant is my oxygen that I use all the time, and it is my key that opens up the world. Traveling with oxygen, you need to do the 3 C's. You need to contact, to carry, and to confirm. Contact your doctor's office and your oxygen company as far in advance as you can. From your doctor's office, you need to get a letter and also a copy of your prescription, which you probably have never seen. It probably went right to the oxygen company. If you're lucky enough to have an oxygen company that is nationwide, they can get you supplies wherever you are landing or traveling to. I go to Cleveland Clinic a lot. We call and we can usually get a concentrator there to have in the hotel room for overnight. COVID is making that a little bit more difficult. So again, you want to contact those people as soon as possible. Carry with you that prescription and the letter from the doctor and some extra supplies. This is my little expert thing here to take. Make sure you have an extra one of these. Not a big deal to have it, but if you don't have it, it's really difficult to open up that tank. These are obviously if you're on a tank. And also this little washer, you may not even realize this little that you have that. It's inside this regulator here, and where it connects, it's where it is, right inside here. And if you blow one of these, you will know it. I first blew one at my benefit when I was very first diagnosed, and I was in a gymnasium full of 300 people. So everyone knew that I blew a washer. I've never forgotten this since that. So I recommend taking those, whether you're in the car or in the plane, whatever. Obviously you can't use tanks on the plane, but if you're using tanks when you land, that's anytime you're using tanks, I would recommend you take a little kit like this. Also an extra cannula. I have had cannulas break here. The official doctors and respiratory therapists do not like it if you call this a nose tube thingy. So you can use the official word cannula. They don't like that word. If you are traveling to a city that's maybe in higher elevation, and you can look this up online, what the elevation of the city you're traveling to, that you may need more oxygen than you currently use, or if you only are using it at night, you might need more. So that's something you want to contact that doctor about. Carry your extra, carry your script, and then confirm with your travel company, with your oxygen company about what you're getting. who's going to be taking care of you when you get there, so that those things are set, because that has been a problem for people. Things get messed up. So you want to make sure you have a contact number. You can see oxygen is a part of my life. I've been as high as 15 liters on exercise. I've had 10 liters at rest. I'm down a little bit right now, but those were the 2 high flow concentrators wide together. All my oxygen sitting in my garage. But what I would highly recommend to anybody, whether you're using B tanks, D tanks, E tanks, O2 concentrators, portable O2 concentrators, or liquid oxygen. I've tried all of these things. Anything that you're using, I would recommend starting with the Pulmonary Fibrosis Foundation. If you go to their website, pulmonaryfibrosis.org, and use the menu to find patients and caregivers, go to oxygen therapy. There is a frequently asked questions about traveling with oxygen. Also, you can find on there the phone number for the oxygen line. That number is 844-825-5733. They will answer any question you have. And obviously, I will try to answer any question you have, but they are the experts. And if they don't have the expert opinion answer right away, they'll get it for you. So they're outstanding. I hope that you were able to get some kind of information from me, and I hope you continue to breathe well. Thank you.
Good afternoon, ladies and gentlemen. My name is Mike Zampella, and I work for Adapt Health. Just a little background on Adapt Health. We're actually expanding our territory to where we now cover mostly the whole United States. So again, that's a good geographical area, especially when you need oxygen and you're traveling, and God forbid, if something ever went wrong, you could give us a call and we would definitely be able to assist if there was a tank issue, possibly a portable oxygen issue, or a concentrator issue. Today's video, we're gonna go over our portability side along with our home concentrator side. So we'll start off with the POC, since that's what everybody wants. It's the latest and greatest. This has its pros and cons. It is a machine, and they do tend to break sometimes. One of the pros about this machine is that it's only 7 pounds compared to this big tank right here, which is probably somewhere around 13 to 14 pounds. This does have a 7-hour battery life. It does come with a car charger along with a wall adapter. It does go up to 6 liters, and we have two administrative ways. We have continuous and pulse dose. Pretty much, if you were interested in this machine, we would just need a prescription for your doctor that states portable oxygen concentrator, and would need to specify either pulse dose or continuous. So a very hot commodity, everybody wants it. Great machine for your people that are still working, are still active, going to church, going to the grocery store, going on vacation. It is FDA approved, so it's good for airlines and whatnot. So again, this is your portable oxygen concentrator, 7 pounds. It has a battery life of 7 hours. Anytime you're in a hospital stay and you do require oxygen to go home with, you would receive the E-tank as an Edward. This tank right here, depending on your liter flow, would be what you would use to go home. On 1 liter, it has 11.3 hours. On 2 liters, 5.6 hours. On 3 liters, 3.7 hours. On 4 liters, 2.8 hours. And on 5 liters, 2.2 hours. Real easy to use. Our certified technician, when he comes to drop it off, will go over how to turn the tank on, along with taking the regulator off and putting it back on, which I will demonstrate that for you right now. So right now I have the tank on, and I have the regulator on along with the toggle. So if I went ahead right now and I turn this on, you would hear the oxygen coming out. This toggle right here is just used for when you first put your regulator on, you turn it on. After that, everything is controlled by the dial. So what I'm gonna do is I'm gonna go ahead and turn this off, okay? Now, if I went ahead and I took this regulator off, you would hear a big burst of oxygen. So I don't recommend that for my elderly patients. So what I normally tell them to do is just go ahead and turn the gauge all the way open. You'll hear the oxygen come out. When it stops and you don't hear any more, go ahead and turn it back to 0. And now you're safe to take off the regulator. So this regulator has 2 prongs on the bottom of it, and the tank has 2 holes that the prongs go into. Those are the only holes on the tank in order to put on the regulator. So with the regulator, you always want to make sure that the prongs are facing the ground, never to the ceiling. And then when you go ahead and you're going to hook it up to your tank, there's only one way to do it. You would lift the toggle up, you would go ahead and put the regulator over the toggle, push the prongs into the holes, and tighten it. Just make sure that when you have your regulator on your tank, that your regulator is straight and it's not crooked, because if it is crooked, the oxygen will leak out. So now, since I have the regulator hooked up to the tank, all I need to do is turn the top of the tank on with the toggle. Now, all you have to do is just half a turn. If I went ahead and I turned the dial right now, nothing would come out. So once I go ahead and turn it, just a half a turn, you'd feel a little pop. And now if I turn the regulator on, you can hear the oxygen coming out. That's pretty much it. When it comes to your tank, here's your nasal cannula. You would hook your nasal cannula up to the bottom of the little connector, and then you would put it on. Just know, when you are storing these tanks in your home, it's very important that you do not store them in closets due to static electricity. God forbid if this tank was ever leaking and it combined it with the static electricity, it could possibly start a fire. Also too, when you're storing them right now, it's okay that the tank is sitting straight up because it's in the cart. But if you had them at home, you wouldn't want to just stack them up and just leave them standing up, because if they do fall over, they could possibly shoot through your home like a torpedo. So we do recommend to keep them out of closets, along with keep them out of the reach of children, pets, somebody that's probably going to try to fool around with it. You just want to put them somewhere, lay them on their bellies in a safe place to where you're able to get access to it, God forbid if you ever needed it. So this is your e-portable system, as in Edward. They do come in 3 different sizes. We have D tanks, as in dog, and then our smallest tank, which is our M6 tank. That tank is usually prescribed for your patients that are able to tolerate a pulse dose and don't need a continuous oxygen, to where every time you breathe, it gives you a pulse of oxygen. It's not really made for your patients that breathe through their mouth, because you got to be able to trigger it through your nose. So this is your portable system. This is what you would most likely be receiving when you discharge from a hospital, a nursing home, or a doctor's office. So now on to our home units, which is our concentrator and our home fill system. I will go over our concentrator first. So inside this concentrator is a 9-volt battery. The reason for the 9-volt battery is if the concentrator wasn't getting any power, there would be something that would trigger the alarm to go off to say, hey, look, it needs to be plugged in, there's no power. So when I go ahead and I turn this machine on, it's gonna alarm for 3 seconds. So that alarm just lets us know that that battery inside the machine is still good, because it does need to be serviced when we do preventative maintenance to this machine. So when I go ahead and turn the machine on, it's gonna alarm for 3 seconds. And once the alarm turns off, now the machine is ready to use. So right here is your gauge. This machine goes to 1 to 5 liters. We also make machines that go from 1 to 10 liters. Just make sure that oxygen is prescribed. It is prescribed through a prescription, so we don't want to go ahead and mess around with it and just turn it up to whatever number we feel we want to put it on. Again, it is doctor prescribed. It is prescribed for a reason. Too much oxygen can make you acidotic. In this case, inside this gauge right here, it goes 1, 2, 3, 4, 5, and there's a little ball that that when you turn the machine on comes up. The bottom of that ball sits on that line of the prescribed number you want to be on. So if you're on 3 liters, you want to make sure that the bottom of the ball is on the 3-liter line. Oxygen can tend to dry you out, so we do have an option to use water, which I will go over that as well. Right now I have it hooked up to a straight Christmas tree adapter that's recommended for your patients that are somewhere between 1 and 2 liters. 1 to 2 liters tend to not really dry you out as much as 3, 4, and 5 do. So again, I have it hooked up to a Christmas tree adapter right here. For some odd reason, if you did want to use the humidifier bottle, it's right here. You would just unscrew the Christmas tree adapter. Now just know that if this isn't something you're going to use, just make sure that you keep this in a safe place, because sometimes we do receive a lot of phone calls that the humidifier bottles aren't working because they're old, they were never replaced, they had tap water in them instead of distilled. Tap water does have a lot of minerals, so it tends to clog the bottle. Inside here is a straw, and at the bottom of that straw is a little tiny pinhole that creates the humidification inside the bottle. You want to make sure that you're changing these bottles out between every 2 to 3 weeks. They do come in your package, so if you do need more bottles or tubing, feel free to give us a call and we can drop them off when we deliver you tanks, or we can UPS them out to you. Now, one of the biggest pet peeves that I see, and it's not a pet peeve, it's more of an issue, is with our elderly patients when they go ahead and they add water to their humidifier bottle. Now, with this bottle, if you actually don't put it on right, you can cross-thread it. So right here, it's on right. If you look at the bottle, all the way around, it's perfectly leveled. Now, there are times where if you're not paying attention, you could cross-thread it, and what happens is if you look at it right now, you see here it's like really low, and as I start to spin the bottle, it starts to get higher. You always want to make sure that there's a good seal there. If I went ahead and I had it cross-threaded and I hooked it up back to the concentrator, it would actually still bubble, but you wouldn't receive any oxygen. And eventually in time, your machine would start to alarm because it would create back pressure. So that's one of the first things we ask when you do call and you are having issues. Hey, how's your humidifier bottle? Did you recently just change the water? Did you make sure you didn't cross-thread the cap? Another way to test it is when you do have it hooked up right, if you want to hold your finger at the end of the nozzle and let go, you would hear like a sprout of oxygen. It would just let you know that there is oxygen coming out. Another way to test to make sure that you're getting your oxygen is taking one of your nasal cannulas, getting a cup of water, putting your nasal cannula in the cup of water, and you'll notice bubbles. So that's another way to check to see if your machine is producing oxygen. And then last but not least, we have our home fill system. These are for our patients that want to fill their tanks at home and are okay with not needing a POC or tank delivery once a week or every 3 days. So basically you have the option to fill your tanks at home, which you would receive 3 tanks. This is an ML9 tank and this is an ML6 tank. Depending on your prescribed liter flow is how long these tanks would last. So again, when you do get set up with this system, our certified technician would be able to go over that with you when they teach you how to use the machine. What's good about this machine is it has 2 levels. I know it's kind of hard to see it, but there's a top level and a bottom level. So pretty much the bottom level is for you to use when you need your oxygen. So you can take your oxygen from the machine and charge your tanks at the same time. This tank right here would probably take the ML9 tank would take about 3 hours to charge, to where your ML6 tank would take about maybe an hour and a half. So again, when you do have this system, you get 3 tanks. They do come with bags, and it all depends on how what your liter flow is. These are pulse dose tanks, so every time you breathe, it will give you a pulse of oxygen, to where this tank right here, which is your E tank as in Edward, has a continuous flow. So if you were on 2 liters, you would just get a continuous flow of 2 liters of oxygen. Again, that would last you 5.6 hours. For any reason, if you do have any questions, we do have a 24-hour service, 7 days a week, holidays included. We usually have a window between 2 and 4 hours when we do need to make a service call. There is always somebody there to be able to answer whatever questions you may have. If you need more tanks, if you need more tubing, all this tubing is in your package. So it doesn't matter really how much you order. If you need more, you can pretty much order as much as you want. You know, as long as you're using it and you're not storing it away in a bin, there wouldn't be any problems if you do need to order more. That's pretty much all I have for you today. So we have our portability side along with our concentrator side. This is Michael with Adapt Health. Thank you for tagging along today and listening. If you do have any further questions, feel free to give us a call at our 1-800 number or our 302-323-8700. Thank you. Have a wonderful day. May God bless you and enjoy.
Hi, everyone. Thank you again to all of our speakers for all of that great information. Every time that I attend an oxygen talk, I always learn something new, so I really appreciate it. We have quite a few questions, so I'm going to go ahead and jump right in. You'll see that we have Melissa and Susan here with us. Unfortunately, Mike was unable to join us, but if you go into the details for this session, you can see his email. It's mzampella@adapthealth.com. But again, if you go into the details for this session, you can see his email and you can reach out to him directly. I want to start actually with something from his talk. We're getting some questions about the POC, that portable oxygen concentrator that he had mentioned at the top, about how much it can, how much battery life it would have if you had it on continuous, which I'm not 100% sure for that specific one. But Susan, can you talk more to resources so that people can compare portable oxygen concentrators as far as their battery life and that kind of information?
Yes, I think that's a critical piece for people to be aware of. So there's a huge variation between POCs. Even a POC, one brand might be set at 2, a pulse setting of 2. It may deliver a different amount of oxygen compared to another POC with that same setting. The key piece is understanding what your POC delivers and if it is a pulse setting or continuous. And as our speaker mentioned, the only ones that deliver continuous only go up to 3 liters per minute, and those are 22 pounds. The rest of POCs are at a setting, so it's not a liter flow, it's a setting that will range normally between about 1 and 5. And on those settings, it's a pulse dose, and again, there's great variation. So the only way to truly know if it's adequate for you is to check your saturations on that POC. There are some resources. We have a colleague of mine, Chris Garvey, developed a POC kind of a cheat sheet, and we'll make sure we can put that out. Kate, maybe we can talk about how that can be accessed. It's very helpful so that when you are considering having your DME choose a POC for you to use, you understand the pros and cons. So again, he pointed out the limitations is that it's a pulse setting. And for some patients with interstitial lung disease at higher respiratory rates and shallower breathing, it may not trigger effectively. So you need to check your saturations during exertion on that POC. And we highly recommend, if you're considering purchasing one out of your own pocket that are costly, that you check with your care team and make sure that that will deliver adequate oxygen and going forward, because your needs may change.
Thanks, Susan. And like I said, we have quite a few questions today. Unfortunately, we probably won't be able to get to all of them, as well as we'd also like to be able to share this resource with people who are interested on comparing POCs. So I would say the best way, if you have specific questions or if you want that resource, is to email us at help@pulmonaryfibrosis.org. That's our help center. And we can help answer some of those questions that we might not get to today, as well as provide that resource on the different types of portable oxygen concentrators. So again, help@pulmonaryfibrosis.org. The next question is about someone who says they have not done a 6-minute walk test. They do desaturate down into the low 80s. And this person is wondering, am I assuming that I would not qualify correctly, that I would not qualify for oxygen, that you really have to have your basic mobility affected before you would be able to get oxygen? Obviously, we can't speak to a specific case, but Susan, can you talk more about sort of, again, how you might qualify for oxygen?
So there are very specific criteria. So it is not based on, for example, how short of breath you are with activity. It's based on oxygen saturation readings that are tested in your clinic or pulmonary function lab with titration, an oximeter on your finger, documenting what you are at rest without oxygen and during walking without oxygen. And some patients have pointed out to us that a walk does not reflect their actual activity at home, where they may have stairs. So it may be that we will take you upstairs, and that's important to let your physicians know that. So that documentation, if your saturation hits 88% or below, then you meet criteria for having an oxygen prescription during exertion, for example. You may not desaturate with rest, but maybe only with exertion. So if you meet that criteria on your oxygen saturations that are documented during a test, those meet criteria for reimbursement, and that order can be sent to a local DME to fill that prescription.
Thank you, Susan. I've got a question for Melissa. Someone says that they're concerned about the noise of their POC bothering people if they go to a play or to a show. Melissa, do you call ahead to see if a venue allows oxygen use?
I don't think that that is a bad idea. I don't think that the POC makes as much noise as you think it does. And so, I mean, things like the heating system in the place are probably going to be louder ambient noise. The POC is ambient noise to everyone else. In my mind, I hear it. And especially if you're on pulse, I can understand where that might be an issue. So if you can have one and run it a little lower, maybe without the pulse, might be a better thing. But I have not personally called, but I think that's probably a great thing to set your mind and ease the idea of whether it's going to be okay or not. So.
Yeah, and I mean, like you said, it's not nearly as disruptive as maybe in the person's mind it is. I would really encourage you, if you can, safely, of course, in the time of COVID, but safely go to these things. They should be able to make accommodations. It's not, there are many people who go around using oxygen. Melissa, you gave great examples. So I want people to feel like they can still go out and do things and not feel like they're going to be bothering people, because really, you won't be bothering people with that. So I really would encourage people to go out and be as active as possible.
When I was on 10 liters and we weren't wearing masks, every once in a while it would get quiet and someone would say, "What is that? Are you leaking?" And I was like, "No, that's actually just my face." But now, especially with the mask covering it, no one really mentions that or can even hear it. So that's one advantage to masks. So who knew?
Mm-hmm. Do either of you have suggestions for methods to avoid tripping over the oxygen tubing, the cording in the home? Anything that you would suggest?
I'll let you do that, Melissa. I mean, I've had patients tell me a few have put actually hooks up along some areas, they can loop it over. Melissa, you deal with this.
Yeah, okay, so I have tried a whole lot of different things, and one of the things that I really stand by is coiling it. And I know this sounds goofy, but there's a right way to coil and a wrong way to coil. If you coil wrongly, when you go to uncoil, it will like knot. And if you coil it properly, and you can look on YouTube for a video on how to coil, like I think in the Navy, they might teach them that with ropes or something. And if you coil it properly, then just one little tug and the whole thing just lays down flat. And when you're getting up and walking towards it, if you're just kind of coiling it in your arm, you're not going to trip over it. The other thing is, it depends, like if my older parents are over, I'm a lot more cautious of that. If it's just us at home, I don't do a whole lot of that. But I do have baby bumpers on my white trim wood, because that rubbing on there can really wear down the wood, but that's not really for tripping, that's for aesthetics. I mean, the baby bumpers still look good, but it's better than the wood getting worn away, so.
There are some biodesign programs and others working on a retractable mechanism, by the way, so that you could automatically retract your tubing and then let it out. So we're waiting for that.
Now, I bought a tube thing at one point, and it needs to be designed by someone working with this, because it wasn't, it didn't work that way. So hopefully it'll come forward.
We've got a couple of questions from people who are on 6 liters, they're on liquid oxygen, and they're wondering about flying with that. Can you speak to what are the options there, or are there options for flying with high flow?
The only FAA approved device is a POC at this time. So that's limiting for high flow patients. And we would recommend that you undergo some high altitude testing and discuss with your physician if flying is safe for you. If you're at high flow, you could argue you could get yourself onto the plane and you're at rest with a POC, maybe set at 6, but then that battery is not going to last very long, and we can't always guarantee you can plug in on a plane. So that's, unfortunately, it is a limitation. We can't fly with liquid oxygen or canisters. So it's only a POC, and you have to have 1.5 times the battery life of the length of your flight. So if it was a short flight, that might be okay if you could maintain your sats at rest on a POC for that short amount. But that's a discussion with your physicians and if you're at high flow.
Someone is asking, will Medicare allow a home stationary concentrator and also a portable concentrator?
And yeah, it depends on the DME.
Okay.
But yeah, so some DMEs, Medicare covers a stationary device and a portable device. So some DMEs will offer a stationary and a portable. We're finding portable POCs are becoming more difficult to find. So in that case, you would get a stationary concentrator and metal canisters. But some do provide a stationary and a portable concentrator.
Okay. Great, thank you. Well, that's all that we have time for today. Again, please email us at help@pulmonaryfibrosis.org if your question wasn't answered. Thank you so much, Melissa and Susan. This is such great information, and I hope everyone enjoys the rest of day 4 of Summit.
Thank you, Kate.
Thank you. Thanks, everybody.
Bye.